Hello and welcome to the session on the biological effects of radiation and cell behaviour by Katie Stupura. So the aims of this session is, first of all, we're going to revise the biological effects that we went over in your first year. So that's looking at stochastic and deterministic effects. Again, we're going to then revise radiosensitivity. But following on from that bit of revision, we're going to look at the reasons for the different radiosensitivities, and then we're going to apply that into different clinical contexts. So mainly we're going to look at paediatrics, female and male, and radiotherapy. So, considering the biological effects of radiation, what do you remember? Well, when we consider biological effects of radiation, the main concern we have is about DNA and the damage that is done to it from ionising radiation. If you remember, the acids in the DNA chain can be damaged. And once this damage has occurred, three things can happen. First of all, they could repair correctly. If this happens, then we don't need to worry about biological effects because it's like it never occurred in the first place. The second thing that can happen is it can repair incorrectly. This is when the DNA chain has tried to repair itself, but it's got the acids in the wrong place. It's repaired incorrectly, which means there's a mutation. This means that the code within the DNA chain is now wrong, and the cell doesn't know how to behave. It's lost its code to tell its behaviour. The third thing that can happen is something known as apoptosis, and this occurs when there's a very high radiation dose and there's a lot of damage to the DNA. Apoptosis means cell death. All cells have a natural cell death cycle, and apoptosis is called into effect quicker than usual due to the amount of damage that's occurred, which means that the cell dies, and if there's a great amount of cell damage, this can affect the organ as a whole. So following on from thinking about the DNA chain being damaged, let's think about stochastic effects. What is it that you remember about stochastic effects? Well, stochastic effects are due to the DNA mutation. So this is when the DNA chain has been damaged, it's repaired, however it's repaired incorrectly, but doesn't know that it's an incorrect repair, which means that the code, the way the acids are lined up within the DNA chain are incorrect, and this is a mutation. The DNA chain can then go on to divide and replicate, and if it does that and it doesn't know that it should go through apoptosis and it just keeps dividing and getting bigger and bigger, this can turn into a cancer. However, if the DNA mutation is also occurs in the cells that we use for offspring, then this can be genetic effects seen in later generations. So, deterministic effects. What do you remember about deterministic effects? Well, the deterministic effects that are seen in tissues is due to the apoptosis. So this is due to the DNA chain and the cell actually dying. And so you're looking at kind of damage rather than risk of cancer when we think about deterministic effects. So this is things like cataracts if it's in the eye, erythema, which is skin reddening, or tissue necrosis when there's enough cell death to actually start killing organs. So we've now revised biological effects, and hopefully you can remember about stochastic and deterministic effects. We're now going to look again at radiosensitivity. So thinking about radiosensitivity, what is it that you remember? Well, with radiosensitivity, we want to look at the fact that different organs and tissues within the body respond differently to radiation. The International Commission on Radiological Protection, the ICRP, gives tissue weighting factors, and these weighting factors follow on to calculate effective dose. If you can't remember this, then access the lecture from first year on the biological effects of radiation. So these tissue weighting factors are based on the risk to these organs of getting cancer. So we're looking at stochastic effects and the risk of getting stochastic effects from a radiation dose. So looking at the list here, this is from the ICRP report 103 that came out in 2007. You can see here that bone marrow, colon, lung, stomach, breast, and these remainder tissues altogether are the most radiosensitive organs. Then gonads are the next radiosensitive, then bladder, esophagus, liver, thyroid are all similarly radiosensitive, with bone surface, brain, salivary glands and skin being some of the least radiosensitive. So we've looked at radiosensitivity in the list of radiosensitive organs as defined by the ICRP, but we now want to look at why different organs have different radiosensitivities. What is it about the organ that makes them more susceptible to radiation damage or risk of getting cancer from radiation than other organs? Well, there are three factors that come into play when we think about radiosensitivity and how sensitive to radiation a tissue type is going to be. The first is whether the first is about the mitotic rate. So how fast does the cell divide? And if it's got a fast cell division, so it's rapidly dividing, high mitotic rate, high proliferation, this means that if a cell has got mutation and is damaged, that damage will proliferate more quickly due to the fast mitotic rate. The next thing that needs to be taken into consideration with radiosensitivity is how well differentiated a cell is, and this is how well developed is a particular cell, and this is known as differentiation. So if a cell is very undifferentiated, this means that it hasn't assumed characteristics that it will later have. And one of the most undifferentiated cells is obviously the stem cell, which can go on to become any other type of cell through differentiation. So a stem cell that is undifferentiated is very radiosensitive. The third thing that affects radiosensitivity is its mitotic future. If it has a long mitotic future, and so it's going to continue to divide over a long period of time, that increased potential for proliferation of a damaged DNA chain is there. And so if it continues to divide over a long period of time, it has a long lifespan, and so will be more radiosensitive. So the three main things are looking at fast mitotic rate, undifferentiation, and long mitotic futures. So following on from those three factors that create a radiosensitive tissue, we're now going to be looking at the different tissue types that we can break this down into. So we've got vegetative intermitotic tissue cells known as VIMs, differentiating intermitotic cells known as DIMs, multiple connective tissue cells MCTs, reverting postmitotic cells RPMs, and fixed postmitotic cells FPMs. So looking at VIMs, so vegetative intermitotic tissue cells. Well, these cells are rapidly dividing and they are undifferentiated. However, they do have a short lifetime, but because of how fast they divide and how undifferentiated they are the most radiosensitive cells within the body. And the cells that thinking about that are VIMs are things like the basal cells of the epidermis and the crypt cells of the intestines. So if you think back to the list of radiosensitive organs, the colon is one of the most radiosensitive organ, and that will be linked to these crypt cells within the intestine. The next type of tissue is differentiating intermitotic cells, DIMs. Now, VIMs are highly undifferentiated, and they differentiate into DIMs. So DIMs are a production from the division. Once a VIM cell divides, they become a DIM. These are still highly mitotic, but as they have been produced from VIMS, they are the next level in differentiation. So they're not as differentiated as VIMS. And they are the next tissue type of radiosensitivity. So they're still radiosensitive, but obviously not as radiosensitive as the VIMS, because of that differentiation difference. So you're looking at things like red blood cells and muscle cells. MCTs. Now these are highly differentiated cells, but they still do divide. So they do have mitotic rate, but it's not a fast mitotic rate, and they don't divide regularly. So this means that they do have some radiosensitivity, but this is only moderate compared to VIMS and DIMS. So you're looking at endothelial cells such as blood vessels and fibroblasts such as connective tissues. The RPMs, the reverting postmitotic cells, these are highly differentiated and are very long-lived. So these are considered as relatively radiosensitive, so they're quite hard against radiation, and you're looking at things like the liver. The fixed postmitotic cells, so these are highly differentiated. They are the most differentiated of all tissue types, and they do not divide. Once they have reached this cell type, they are not going to divide in any way, so they have no mitotic rate and no mitotic lifespan. This makes them radio resistant. So even if one cell has DNA damage, if that damage isn't going to proliferate or spread in any way, there's no there's no proliferation of that damage, then nothing will be seen. It's just that single cell that is damaged, and it's things like nerve cells that are FPMs. So following on from the different tissue types, this leads us to understanding why with the different tissue types we have different types of organ response to radiation. So we need to consider acutely responding organs, and these are the organs that become easily injured by radiation very quickly after exposure. So they are easily injured due to the fact that they have a high degree of cellular proliferation. So those cells are dividing very quickly, and so that damage is spread across the organ very quickly. So you're looking at things like bone marrow, GI tract, skin and testes. Late responding organs are obviously the complete opposite of acutely responding organs, and this is due to the fact that they have a slower rate of cell division. And so if there is a DNA chain that's been damaged, if it takes a long time to divide and proliferate that damage across the organ, then they will still respond, but it will be much later on. So injuries in these types of organs may not be seen for very long periods of time. So you're looking at damage within the lungs and within the kidneys. So considering all these factors, you can see now with this list of radiosensitivity with bone marrow at the top and nerve tissues at the bottom, how that list from the ICRP has been established in terms of radiosensitivity. So now we've looked at the reasons for different tissue sensitivities, we're now going to consider applying them to different clinical settings. The first clinical consideration I want to make is about paediatrics, and there are two factors we need to consider with paediatrics. The first is that because they are still developing, they have a faster cell division than adults do. So they've got this quicker mitotic rate than adults. And linking back to radiosensitivity, this means that naturally they are more radiosensitive, and obviously this changes with age. So with younger people, they are more radiosensitive as they get older, and their mitotic rate slows. So that's how radiosensitive someone is naturally, but we also can't forget that if some of these late effects aren't going to be seen for kind of 50 years, the fact that a paediatric has a longer life expectancy does come into play. For example, if a damage happened to a 90-year-old and that effect isn't going to be seen for 50 years, it's unlikely that that particular person would see that biological effect in their lifetime. However, if that same damage was done to a 2-year-old and the damage will be seen in 50 years, there's much greater chance of seeing the effect within their lifetime. So we have to take into account both the fact that they are naturally more radiosensitive, but also they have a longer life expectancy to actually observe the biological effect as well. So, for practical considerations when imaging paediatrics, you need to reduce the MA, and this is quite obvious. However, this is often done basically because of size, and so to get the appropriate image. However, with DR, this does need to be considered because obviously there's less implications on image quality with high MAs. So, try to consider that it's not just weight-based, because actually smaller children are actually more radiosensitive as well. So how can you bring that MA down as low as you can while still getting a diagnostically acceptable image? Linked to that, you may want to consider high KV techniques instead, thinking about high contrast, inherent contrast areas such as the chest. Non-grid techniques, do you really need to use a grid for paediatrics? Also thinking about chest x-rays in females under 16 and whether you do AP or PA. The highest dose is going to be on the surface of the tissue that is facing the x-ray tube. And breast tissue is highly radiosensitive, especially in developing females. So considering the direction of the way you take a chest x-ray, obviously for the other reasons as well in terms of geometry, but to reduce radiation risk. Also think about the correct application of gonad shielding and whether it's appropriate or not following your local protocols. So we've now looked at paediatrics. I'm now going to move on to consider females and males. Well, as well as our organs all having different radiosensitivities, actually we all individually have different radiosensitivities, but also between male and females, radiosensitivities varies. Women have a greater mass of breast tissue, and breast tissue is a highly radiosensitive organ, and so that increases a female's radiosensitivity. And also in females, the thyroid is more radiosensitive. In males, their bone marrow is more radiosensitive, but overall, women are about twice as radiosensitive as men. Now, remember what we're talking about here is stochastic effects. So, women are twice the risk of getting cancer as males when exposed to ionizing radiation. We are twice as sensitive. So, I've gone through female and male. And now I'm going to concentrate on radiotherapy. Well, generally, cancer cells, not all of them, but generally, have a high mitotic rate, so they divide very quickly. And because their DNA code has been damaged, they are undifferentiated. This means that they are more radiosensitive than other tissues. This means they get more damage and repair slower than their surrounding healthy normal tissues that surround the tumour. But please remember that not all tumours have the same radiosensitivity. So when considering radiotherapy, very, very high doses are prescribed, and this is when we move away from risk and we're actually looking at damage. So radiotherapy takes advantage of the deterministic effects and actually starts causing apoptosis within the tumour cells, causing those cells to die and eventually the tumour. So the way that radiotherapy is delivered is via something known as fractionation. And this is where, if that tumour has been prescribed 20 grey, it will be divided up, say, in 10 2 grey lots. And the reason for this is to allow the normal tissue to repair, remembering that first of all the tumour is going to get more damage than the healthy tissue. It's also going to repair much more slowly than the healthy tissue. So you give the tumour the 2-grade dose. You wait a period of time to allow the normal healthy tissue to come back up. The tumour will not repair. Then you deliver more dose, the tumour gets more damage, the healthy tissue gains some damage but then repairs again, etc, etc, etc. So the healthy tissue should stabilise eventually back to healthy tissue, whereas the tumour slowly deteriorates over the fractionation period. There are other reasons for fractionation, but I'm not going to go into that today. Just a note as well on radiotherapy that it's not just the fractionation that causes the healthy tissues to be at lower risk than the tumour, and it's not just the radiosensitivity of the tumour as well. It's also done via planning, which is where the beams of radiation kind of placed over through the tissue, avoiding highly radiosensitive organs, but also layering up. If you see here, there's a beam put across this way, a beam put across this way, and a beam put across this way. That means that the region with the tumour in receives the most dose, whereas this area and this area only receives about 1/3 of the dose. So the planning and the fractionation ensures that the normal healthy tissue is exposed to as low a risk as possible. But also please remember about justification and the fact that this particular patient definitely has a tumour. You can justify the higher risk of stochastic effects in a patient. So thank you for listening to this session. We went over again the biological effects of radiation, radiosensitivity. We then followed on from that and looked at the reasons for different tissue sensitivities, and we looked at them in certain clinical settings such as pediatrics, female, male, and radiotherapy. So some useful resources, I will put links on Blackboard to these, is some training courses for pediatric imaging. This is mainly for CT and interventional imaging. However, the theory and the philosophy of radiation protection for pediatrics can apply across all use of ionising radiation. There is a guide to radiotherapy and safety from the Health Protection Agency, and the IAEA has general radiation protection information for healthcare professionals. These are the resources I use throughout this lecture, so looking at radiobiology for the radiologist. The Rickson paper from 2008 is a summary of the ICRP recommendations, and that's quite a useful article to read if you're interested in biological effects of radiation and how the ICRP developed their weighting factors. The Alliance for Radiation Safety in Pediatric Imaging is a new American website where they're trying to improve pediatric radiation safety, and the Health Physics Society, the HPS, is a good use of website for resources. Thank you very much for listening. I hope you enjoyed the talk. Many thanks.